Yes, good day, dear patients, dear patient representatives, and all interested parties. I warmly and very warmly welcome you, and today we are comprehensively reporting from the ESMO Congress 2024 on the topic of advanced prostate cancer. My name is Klaus Kronewitz. I lead the Prostate Cancer Self-Help Group, Berlin North. I am also an active part of the Patient Research Council, NCT Berlin, and involved in various activities, other committees, but that would go too far here. Yes, for me, it is always important that patients can only fully competently decide about their situations if they are optimally informed and aware. And we have this unique opportunity here at Patients Today. Today, we will also learn about the latest developments in advanced prostate cancer and additional insights. We are discussing together here how this affects everyday treatment. For this, I am allowed to warmly welcome the esteemed Professor Merseburger. Professor Merseburger is the director of the Department of Urology at the Lübeck campus of the University Hospital Schleswig-Holstein. He is also a member of the Oncology Working Group, a member of the European Guidelines Commission, author and co-author of over 200 publications, and a member of numerous professional societies and important committees. And last but not least, he is, of course, involved in various studies, which is extremely important. We have very thoroughly and meticulously selected studies together. As I had already said, and I think I will now hand over to you, Professor Merseburger.
Yes, Mr. Kronewitz, thank you very much for the kind introduction. The most important thing is, I believe, also that I was now on site at the European Cancer Congress. So at the ESMO Congress, because it's always like this, you can look up a lot of things nowadays or listen to it later, but it is always more beneficial to be sitting in the front row and, so to speak, like to discuss all this with colleagues, place which is important for you, dear patients and relatives. And we have comprehensively addressed prostate cancer for you today and will provide you with the latest information discoveries show. It might also be important initially, alongside the disclosures, to mention again that many of these developments, and here are many companies with whom we are working on studies, such as the first one we would like to with you, want to share that while these are sometimes indeed very good, groundbreaking results, that you cannot always immediately implement in the clinic. I think that is important. And many patients ask afterwards, knowing that someone attended a cancer congress in America or in Europe, and then ask here, Mr. Merseburger, what is new there? And then I like to tell that, but sometimes there's also a congress where such early phase 1 studies are typically found in clinical research where there is not yet a change in treatment. At this year's ESMO Congress, it was such a mix. There were truly groundbreaking results, particularly on bladder cancer, but also on prostate cancer. And with that, we would now like to start. We have selected a handful of exciting studies for you. The first study, it is specifically about the lutetium radioligand PSMA-617 in comparison to other hormone therapy. The study, this so-called PSMAfore, that is this PSMA therapy, is currently approved after hormone therapy and chemotherapy no longer work effectively. And then you can use Pluvicto as an approved medication in Germany. Now, in the PSMAfore, that is beforehand, examines how it is before chemotherapy, whether there is also good efficacy, and patients were selected into 2 arms, either the second ARPI, something like, for example, enzalutamide, such as abiraterone, for example, and 6 treatment cycles of the radioligand therapy, the 177Lu PSMA-617. I won't keep pronouncing it, so the radioligand therapy. Indeed, the primary endpoint was radiographic progression-free survival. That is the time until the tumor grows further, until it is visible in imaging, new bone metastases or lymph node metastases have occurred. Then there is still other endpoints, such as the time to the occurrence of skeletal symptoms, quality of life, and pain. All of this was examined and measured in the study. So here are comparisons, one arm with the other arm. Here, certainly, the ARPI switch would be a possible therapy option. And the alternative is this radioligand therapy with the advantage, perhaps still not needing chemotherapy.
May I briefly interject here?
Of course.
I would like to know, how is lutetium administered? Is it a kind of infusion, or how should I imagine it?
This is an infusion that is also administered by nuclear medicine specialists on an inpatient basis. So it is basically a key lock principle. The PSMA expresses or is indicated by specific prostate cancer cells, and there this ligand can dock and then deliver radiation precisely on site. Therefore, it only works if the tumors are PSMA positive. So you need to perform a PSMA PET imaging beforehand. If they are positive, which is in 90%, if that is indeed the case, then this therapy has a possibility to work.
Thank you. I believe that is a very important point for all patients, that a PET CT should be done beforehand.
Yes, that is important.
Good, thank you.
What came out of that now? So as I said, we have discussed gladly that we play the ball back and forth, and feel free to interrupt if questions arise. It turned out that there are fewer bone fractures and skeletal events in the radioligand therapy arm have been observed on the left side. See here from the numbers, 11% compared to 26%. That is already twice as much in the AP switch arm. And the time until the onset of symptoms of poorer quality of life and pain was also extended in the radioligand therapy arm. This means exciting data here on the use of lutetium.
Could you, if you could, go back one, please?
Well, why?
I would also like to know again, what is the situation with side effects? This is always very important for us as patients. So pain, fatigue, or symptoms such as nausea and vomiting. Can you say something about that?
Yes, the quality of life was consistently better with the radioligand therapy. You see this with the quality of life and pain questionnaires shown below, the time until the next pain event. So overall better compared to the AP change. And maybe I'll go to the next slide. This is all very good. Perhaps that means it makes a lot of sense. What does this mean for everyday treatment? What is often criticized is that one would have actually wished for chemotherapy in one of the arms, because the study doesn't tell you whether this is better than if chemotherapy had been given. That's kind of the crux of the matter. According to our current guidelines, AP-ARPI, meaning enzalutamide, and then abiraterone, or apalutamide, and then enzalutamide. That doesn't make sense. One should change the mechanism of action. Regardless, it has once again been confirmed that radioligand therapy has an established significance in metastatic castration-resistant prostate cancer, and perhaps also move a step forward. That was the important conclusion of the PSMA preliminary study that we saw recently. Now at the ESMO 2024. Mr. Kronewitz, do you have any questions?
Yes, I find that very interesting. And I can only say from my group, I can also report about a group member who, on his own initiative, ultimately preferred this because he refused chemotherapy and has achieved outstanding success. Well, naturally, given the circumstances. And that's what I wanted to say at this point. I strongly believe that this particular topic is of great interest to our dedicated listeners and viewers. What does it look like in practice?
Yes, I just have to warn a little that this is not yet approved. And even if you think everything is great now, please follow the recommendations of your colleagues, and ultimately also to the approval. They have a reason why a European authority has not yet approved something. This will be discussed by experts on site, and sometimes too much self-initiative is not always effective. And case reports are sometimes good, but those who are frustrated when it doesn't work well, they usually don't report that either. That can be a certain mistake.
Very good. I can fully support that. And here is another appeal to everyone to truly adhere to the S3 guidelines, and once again. And you can also find them on the internet, and every good doctor will report accordingly as per the established medical guidelines and protocols.
But as I said, it may well be that this now moves forward in the approval process, and that what you indeed reported about your patients, Mr. Kronewitz, since it worked this way, it might work for other patients in the future, can now also be offered in the same situation. So exciting data on radioligand therapy. If it's all right with you, I would like to, if possible, move on to the next study. We are indeed in the same situation, namely metastatic prostate cancer, after the initial failure of hormone therapy treatment. And here, an important study, the TALAPRO-2 clinical study, which led to that talazoparib and enzalutamide are now indeed independent of genetic alteration. In the situation of metastatic castration-resistant tumor, this is approved, and here it should be checked once more. What are the potential side effects between germline and somatic changes? So the two arms, and it was carefully checked whether these genetic changes in the study accompany the side effect potentially That's why I found it very exciting, and Mr. Kronewitz, I believe you did too, to see if perhaps patients with specific genetic alterations or mutations familiarly have more or less side effects than the acquired somatic genetic changes that can develop over time in the tumor.
Exactly. What scale are we talking about here? Approximately what percentage of people are affected by this?
Approximately 15% of men are in that stage who have either a somatic or a germline mutation, such as are affected by it. And that's where these pair inhibitors, talazoparib, act, what I am circling here, very, very good. But even without these changes, the combination works better. Only enzalutamide definitely here with it. Now, they indeed also have this combination, which works well, certain side effects, mainly the changes in blood count, such as anemia, and such as few white blood cells and platelets. And here it was shown that patients with germline mutations, such as those found in their DNA, had fewer anemias, meaning less anemia, than with the somatic, indeed, the acquired changes. What does this help us with in practice? Not really much, because the side effects can occur with both. Perhaps one is then better prepared because one perhaps knows someone with a familial change, suffers more from anemia or related issues. These are the following results of this study. Here is a summary once more, again, for everyday treatment practice. Patients with a somatic or indeed acquired gene variation should perhaps be monitored more closely and frequently. I still think it's good that we're talking about it here because the pair inhibitors, that is all this genetics, are very important. And from the castration-resistant stage, the affected men should know that not only to advise the family, but also to know whether one should now administer PARP inhibitors or perhaps rather an alternative like the radiohydrogen therapy just shown. Mr. Kronewitz, now I hand over to you again.
Yes, if I may, I just have one more question. Could you perhaps tell our patients and those interested a bit more about how is the whole thing diagnosed? How is the diagnosis? First, I need to determine if I belong to the 15%.
Important point. Good that we are doing this together. So one option is either a blood test. So you can draw blood similar to the PSA test. For example, one can determine germline mutations. Somatic mutations are also very well determined from the tissue. So the existing tissue, for example, from the prostate surgery or from the biopsy, this can be used for that or both. And sometimes you only find that with one or the other. Therefore, it makes sense to test again at a later stage, perhaps to take another sample from a metastasis to verify the gene status once again.
Good, thank you indeed.
All right, okay then, let us return back to the prognosis prediction model. And sometimes patients do ask that, how much longer do I have to live? That is a difficult question. What is your response to that, Mr. Kronewitz? I sometimes say, how long do you want to live? Then they are mostly astonished and say, well, my son's or my grandchild's high school graduation next year, want to see that. And you can say, we can achieve that with the new possibilities. That's difficult to answer.
Yes, and that is always subjective. First of all, what phase am I in? And will 3 or 4 months sometimes already help me? That sounds a little bit strange now, but it is really so because I have experienced cases in my group who were then indeed very accordingly happy that they were able to settle some things there. But there are also cases where in some cases the patients really then surprisingly live significantly longer than predicted. I also know cases in our group. And it's always so absolutely wonderful when you truly meet with them together and then see what progress has been made in medicine. Like in the meantime, I always say that medicine is making progress, especially in this area, a quantum leap every 5 to 10 years.
Yes, I completely agree with you. And that's why I thought it was good that this working group, like Susan Halabi once looked at it, and perhaps also just to know where the journey is heading or where we stand. When we treat a man with hormone-sensitive prostate cancer nowadays, and here overall survival was examined and then correlated with many different factors, one simply needs to know where the metastases are, was prostatectomized, there was radiation therapy beforehand, how old is the man, and so on. And essentially a predictive model has essentially developed from it regarding the overall survival of the patients or the men to predict with a metastatic hormone-sensitive prostate carcinoma. And
sorry, just briefly, something like this can only be done retroactively. So probably, well, I don't know, data has been examined retroactively, or how did it go?
This is what I wanted to show with this slide. As I said, I can always gladly jump back again. But here the median follow-up is 60 months, which is 5 years. So long was looked back. On average, the men were 70 years old. That's how most men feel in the middle of their lives. But it's not like that. One must not forget. No one lives to 140, but sometimes that's just how it is. Now, we are on the other topic, early detection, from 45, not just from 70. Most men come at 70. Professor Merseburger, I wanted to come in for early detection. Am I not allowed? So as I said, this is the middle age where advanced prostate cancer is already found. Therefore, also gladly to your group to send people early for early detection so that one does not have to treat the spread cancer at some point. And here you can also see that 85% of the men were de novo, were thus discovered with cancer. Indeed, high disease volume, 51%. Some had also undergone chemotherapy. And now you ask me for numbers. We don't have them here. This is a predictive model where you have to enter all these numbers. Well, I can tell you on average now, someone who has de novo metastasized has a high disease volume. Unfortunately, still has an average survival time of about 3 years. But conversely, we also have patients who are metastatic, who survive 8, 10, 12 years. If these factors are certainly indeed for the better here, so not too many metastases, nothing in the liver, but also that, as you said, Mr. Kronewitz, can, with the new medications and therapy options, be always unpredictable and adaptable. It can go in exactly one right direction, that patients can be stabilized for years. Where exactly does this help us in this particular situation? We know that if we have a poor prognosis, it does not mean you only have 2 years left to make your will. That's nonsense. One should make a will by the age of 50 anyway, and regardless of the illness. But I think it's important to know, now one has an aggressive cancer with a poor prognosis. Now we can take care of it. Now we need to monitor PSA more frequently, now we need to perform imaging more frequently. These are, I believe, important statements of this prognostic model, which can also be included in new studies.
I personally find that to be quite important, regardless of the situation anyway, that one always stays engaged in a way that is consistently and reliably, and always measures consistently and promptly at appropriate intervals. Because I hear that again and again, that the patients then take a longer break, such as taking a nap, or somehow start on your own, taking medication intermittently. So I can really only give a warning, but I wanted to say one more thing, because it is very, very important to me. You had it too, indeed. I am passionate. These are my topics. I am passionate about prevention and early detection, exactly what you said. Then you not only spare yourself some things, but one must also say that those are indeed significant costs. We once talked about 150,000, 200,000 euros for treatment in advanced prostate cancer, and thus one also saves something for the community.
I agree to you. The prostate surgery with everything about it are 15,000 euros, and the metastatic disease, 250,000 to 500,000. Have we just at the German Urologist Congress also saw it again last week? Well, Mr. Kronewitz, thank you very, very much at this point for the studies we discussed with you. Thank you for your interest.
Yes, very gladly. Well, I was absolutely and incredibly fascinated by the element called lutetium, especially because one can now start earlier, and that could be very important, quite important for some people. So thank you very much for the presentation as well. The really very interesting studies. And I can only tell you, dear patients, I must emphasize that with utmost sincerity and care, dear patient representatives and interested parties, feel free to also watch the other videos on the topic of advanced prostate cancer. And we would be very pleased definitely to see you there as well. Absolutely. And then I will say goodbye to you for now. And from the patients, goodbye.
Stay healthy. Goodbye.